Queensland Inquiry. We were able to extract a commitment from the Palaszczuk Mark I government that should they be re-elected, they would have a parliamentary inquiry into the Pharmacy Business Ownership Act, which they did. So that was referred to the Health and Community Services Committee. So that was expanded to incorporate clinical practice as well as pharmacy business ownership stuff. So the two pieces of legislation, the two acts that govern what we do every day, the first one is the Pharmacy Business Ownership Act, and the second one is the Medicines and Poisons Act. So the first one is who can own a pharmacy, how they can be structured, and the second one governs my scope of practice, what drugs I can give, whether I can vaccinate, whether I can inject, my emergency supply provisions, can I prescribe, the whole kit and caboodle. So the first thing is the new Medicines Act comes into effect or is introduced into Queensland Parliament. And I've been trying to do this since Bligh was Premier. It's been introduced in every Parliament and it's never got up. It will be voted on in the Parliament on the 11th or 12th, I think it is, of July. So it's coming in 3 weeks, new Medicines Act. However, you need the regs, right? So the Act gives the framework, the regs is the interpretation of the Act. That is coming in hopefully sometime before Christmas. But nonetheless, this is the furthest progressed we've had in scope of practice since Bligh. What exists in that? So the things on the left-hand side. Basically, this is pharmacist scope of practice, pharmacy assistant scope of practice, which isn't technically a thing, but that's what they referred to it in the inquiry. I'll go through a few examples. First thing is emergency supply provisions. So you know how we have to cut out 3 days worth and give them 3 days worth of drugs, charge them the full amount, get me a script and I do an owing. There's no such thing as an owing, by the way. It's not actually something that technically exists. There's no piece of legislation or an act or anything that says what an owing is. It's a colloquial term, just so we all know. Now the thing is in the Northern Territory, they don't have a 3-day limit on emergency supply. You can give one original pack. So Queensland, touch wood, will be the first state to abolish the 3-day emergency supply provision. So if someone runs out and they come into your pharmacy for everything except an S8, you can just give them a full box, which is a major improvement, right? We already have continued dispensing for statins and oral PBS contraceptives. Basically, this means you can do continued dispensing, right, for everything. It just doesn't attract a subsidy. So one of the challenges for George and I for the 7th Community Pharmacy Agreement is to expand the continued dispensing instrument, so not only can I give it for all privates and general under co-pays, but if someone comes in and they're a concession or pension payment or a patient or a general patient, then I can claim the PBS subsidy. So that is a huge workflow improvement, right? The second thing is to whether or not I can vaccinate or whether or not I can inject. Did you know that pharmacists can vaccinate? Funny enough. Do you know we're not allowed to inject? Doesn't that sound stupid? So I can inject for the purposes of vaccinating, but unless it's for a vaccination, I'm not allowed to inject. So I can legally vaccinate you for influenza, for MMR, for a variety of other things, but if you come in and ask for a vitamin B12 in a 3 ml syringe, I can go, here you go, son, take it home and just jab yourself in the arm. I can't legally give it. That's pretty stupid, right? The other thing is if someone is a first-time patient on insulin, I can open up the CMI on the desk and I can go, this is how you inject yourself, but I can't actually load it and show them and help them with their technique. And that's just technique. So being able to inject unscheduled items, being able to inject for or administer for the purposes of demonstration is another area we are trying to fix up. Just so you know, the AMA said that this is a Chicken Little thing. People are going to die in the streets and all sorts of wonderful things for us doing this. The other thing which I didn't know that I've been doing since 1997 when I first started in pharmacy that's illegal, but I've been doing it anyway, is showing someone how to use an inhaler technique, especially a child. So mum comes in, they've got the script for the preventer, they've got the script for the reliever, and on the bottom, on the tear-off bit, it's got C pharmacist RE spacer. Right? She's freaking out. The kid's never had a puffer before. You go, calm down, Mary Jo. You pick the kid up, you put him on the bench, and you go, I'll show you how to use all this. So you get the puffers. You go, this is the spacer. Do you want to buy it? Yes. You should probably get a mask as well. No worries. Right, this is how you do it. You plug it in. You tell them to sit up straight, empty their lungs, put the thing on their face, dispense it and show them how to breathe it and how easy it is. And she's so relieved because it's not scary anymore and you've demonstrated how to use that device. I've just administered a drug to a child, so I've just breached the Medicines Act in Queensland. So that's stupid, right? Because I'm actually demonstrating how to use proper inhaler technique using a device. So there's all of these stupid things we need to fix up in the Medicines Act. The government has decided to establish a Queensland Pharmacy Council. It will be an interim advisory council to start with, and then once the Pharmacy Business Ownership Act is changed, it will be given proper imprimatur. But these are the people, right? So Tim Logan, the chair, my predecessor, he will be stepping down off the Pharmacy Guild on the 30th of June to take up the role as the inaugural chair of the Queensland Pharmacy Council. So thank you, Comrade Tim, for taking up the good fight. We also have Maria, who is a lawyer. We also have Frank, who is a business advisor. He owns Medici Capital. He may have done some valuations for you all. We have Michael Ryan. He's the hospital pharmacist. Harry Pitt, he's the consumer. He's a Torres Strait Islander fellow. Professor Lisa Nissen, she's a bit of a legend in the pharmacy prescribing space. And then we have the two gurus, Fiona and Lucy, who are on the Queensland Pharmacy Guild branch committee. So thank you, Fiona, for taking that on. Their job will be to provide advice to the minister on changes to those two pieces of legislation. I know I've got to go in a minute. I'll tell you why in a second as well. Clinical trials, we will be able to provide anything consistent with the Australian therapeutic guidelines for uncomplicated urinary tract infections in non-pregnant women. This is not a trimethoprim trial. If you deem cenflexin is appropriate, that's what we should be doing. If you deem macrodantin is appropriate, that's what we should be doing. This is not a trimethoprim trial, which is what the bureaucrats are trying to wedge us into doing, by the way. All right, because that's what it is in New Zealand. But my mum's got a sulfonamide allergy, I'd have to give her cenflexin, for example. The other thing is the oral contraceptive pill. They're not running a trial on that, they're just going to do it. Okay, so we'll be able to give up to 18 months, over a year, of renewing that prescription. Of course, Chicken Little, sky's falling, people are going to die. All right, so this is the scope of practice stuff for vaccinations. As you can see, Queensland, how good is Queensland? We do have 16. This needs to be updated. Tasmania and Western Australia can now vaccinate from 10 years of age and over. Right? So we need to get those ages dropped. The reason 10 is because under the National Immunisation Program, 10 is the beginning of the adolescent schedule. Right? So you've got infants below 3, 3 to 10 is called childhood, 10 to 16 is called adolescent. 16 is the adult. Right? So it's where these ages come from. So we're asking for the adolescent schedule, which is 10 years of age. So that's where that figure comes from. Clearly, we need to get access to the NIP. The other trial they announced, other than urinary tract infections and the oral contraceptive pill, is travel medicine. We need to make sure we're not wedged here by the AMA and the bureaucrats. It's not travel vaccinations. It's a much broader range of things that we may need to be able to do for travel medicine, but we should be able to do all of vaccinations associated with that as well. This is scope of practice in Canada. This is how quick it moves. 2011, provinces across the top, what they can do down the side. This is 2019, 11, 19. So when people say, right, and some of our sister organisations have said this, oh, this is going to take 15 years to get it. Trent, we know you're impatient. Autonomous prescribing happened in 8 years, then we should be able to do it in 5. We should be able to do these things in the context of the 7th Community Pharmacy Agreement. This is not a 10 to 15-year-old goal. Renew and extend prescriptions. Well, that's continued dispensing and the emergency supply provisions. So we're doing that. We're almost got that, right? Change to drug dosage and formulation. That's prescription adaptation. We can't do that yet, right? So make therapeutic substitution. This is not an A-flag generic. This is saying, for example, a girl is on this pill, she's getting breakthrough bleeding, weight gain, acne breakout, I'm going to swap her to another one. Somebody's on an ACE, they're getting a cough, I'm going to put them on an angiotensin, right? Somebody is on a torvastatin, they're getting cramping, I want to put them back on simvastatin, right? So these are therapeutic substitutions within a framework. It's not A-flag substituting. Slightly different. Prescribed for minor ailments. What do you think uncomplicated urinary tract infections are? What do you think travel medicine is? So we're already starting to do all of these things, but obviously there's a greater array of minor ailments that we could prescribe for. And if you wanted to know what our focus on, think of the top 10 potentially preventable hospital presentations, right? Because that's what's costing the taxpayer money. These are the ways that our workforce and our network can provide value. Initiate drug therapy independently. That is autonomous prescribing. Order and interpret lab results. Do you know in Queensland you can already order any lab test you want, right now? You just can't get a PBS subsidy for it, so they have to pay for it, which is why it's not highly or readily utilised. But you can do it right now. It's already in your scope and you can already legally do it. Administer drug by injection. I spoke about that before, right? It's about removing that stupid anomaly between vaccinating or injecting. It's also the fact that a lot of the other new therapies coming onto the market, whether it be in the S100 space or in the high-cost drug space, could be injectable therapies. I'm in trouble. And regulated pharmacy technicians. This is back to front. Having a checking technician, or as they call it in New Zealand, a chicken technician, is not a good thing. This is the only area we agree with the PSA, I have to say. We both feel, right, that only pharmacists should be able to dispense because dispensing is a clinical function that should be reserved for the health professional. SHPA are pushing this barrow because they want to walk around with clipboards and purple pens and actually don't want to do anything. So they're pushing that, not the PSA and not the Guild.